Hi, hello everyone. It's me, Annie Guinocor, and together with my partner, Miss Regine Lim, we will be tackling all about intestinal obstruction. So, are you familiar with intestinal obstruction? What does it mean, diba? So first, let us define intestinal obstruction. So what is intestinal obstruction? So, it is a failure of intestinal contents to move through the bowel lumen. The small intestine is more commonly affected. However, bowel obstructions may occur in the large intestine. Obstruction is the most common reason for small bowel surgery. So, yung mga intestines na naboblock pala, ito pala yung meaning na intestinal obstruction. So, anything na nakakapag-block ng intestinal contents to pass through the lumen is called intestinal obstruction. Kasi hindi nakaka-pass through yung mga content, na-obstruct sila. So, yun yung intestinal obstruction. So, meron bang mga types ng intestinal obstruction? Meron. Meron tayong 3 types of intestinal obstruction class. Yung first is mechanical obstructions, second is functional obstructions, and third is strangulation. So, I know a lot would ask, what does these 3 mean? How does it differ to each other? So, allow me to expand and elaborate each types and also the causes and examples. So, first is the mechanical obstructions. So, what is mechanical obstruction? This is an intraluminal obstruction or a mural obstruction when pressure on the intestinal wall occurs. So, kapag merong pressure, it can be within the intralumen or sa lumen or pwede rin sa walls ng lumen, it is called mechanical obstruction. So, more on physical siya. Like for example, may mga bukol sa intestines or merong pagtutwist ng intestines, more on the physical aspect siya kapag na-obstruct siya. Merong pressure na nagaganap doon sa intestines, kaya hindi nakakapag-pass through yung intestinal contents. So, ano ba yung mga causes ng mechanical obstructions? So, meron tayong 3 ulit dito. Yung una is kapag may problema outside the intestine, ito yung sinabi ko kanina, or mas tinatawag siyang extrinsic. It can be caused by problems within the intestine. So, this is what we call intrinsic. And meron ding obstruction of the intestinal lumen. So, this is what we call intraluminal. So, ano-ano nga ba yung mga examples ng 3 ito? Okay, so una, we have mechanical obstruction causes. Extrinsic. So ano nga ba ulit yung extrinsic? Ito yung mga problema or problems outside the intestine. So we have here the first one, adhesions after surgery. So adhesions are scar tissue. They form between tissues or organs and cause them to stick together. Sometimes they can cause the bowel to get blocked or what we call as bowel obstruction. Surgery breaks up and removes this scar. Yung pangalawa naman, example, is hernia. Okay, so what is hernia? Hernia is a segment of the intestine that may break through weakened section of the abdominal wall. This creates a bulge where the bowel can become obstructed if it is trapped or tightly pinched in the place where it pokes through the abdominal wall. So I have here some pictures for you to have a better visualization. This one is adhesions after surgery and the other one is hernia. So what is the third example? The third example is wound dehiscence. So, bakit? So, abdominal wound dehiscence is the separation of different layers of an abdominal wound before complete healing has taken place. So, ayan. Bago pa siya nag-heal, nag-separate na yung layers ng abdominal wound. So, ayan. Na-obstruct yung bowel. Fourth example is volvulus. So, why? Volvulus occurs when a loop of intestine twists. So, nagtutwist daw siya around itself and the mesentery that supplies it, causing a bowel obstruction. So, ayan. May pictures tayo and that what volvulus look like. Let's move on to the intrinsic examples or causes. So, for the intrinsic naman, we have here the first example, which is hematoma. So, I know a lot of you are familiar with the name kasi paulit-ulit siya na binabanggit in any topic. So, intraluminal hematoma of the small intestine is due to use of high-dose anticoagulation, and thus small bowel obstruction may occur. Ito namang second example is about tumor. Bowel obstruction again can happen when a cancer in the abdominal area is present and presses on the bowel. So, ano ba yung mga example ng mga cancer na ito? Like, for example, ovarian cancer, bowel and stomach cancer are few of the many examples. Other cancers, such as lung and breast cancer, can spread to the abdomen and press on the bowel. So cancer grows into the nerve supply of the bowel and damages it. This can stop the muscles from working. So, ayan. Third is intussusception. So, ano nga ba yung intussusception? Ito ay isang condition in which one segment of intestine telescopes inside of another, causing an intestinal obstruction or what we call as blockage. Although intussusception can occur anywhere in the gastrointestinal tract, it usually occurs at the junction of the small and large intestines. So, ayan, yan yung intussusception. Parang pumasok yung other part ng intestine sa other part niya. And this is common daw sa junction ng small and large intestine. So, ayan. Kaya na-obstruct as you can see. Sobrang konti or wala na talaga yung passage. So, hindi na makaka-move forward yung contents. So, the fourth example is stricture or stenosis. So, ano nga ba yung stricture and stenosis? An intestinal stricture or stenosis is a narrowing in the intestine that make it difficult for food to pass through. So, sometimes it can lead to intestinal blockage. At least 1/3 of people with Crohn's will develop a stricture within the first 10 years of diagnosis. So, ito pala yung pag-narrow ng lumen or ng intestine. Kaya, mas nahihirapan na mag-pass through yung mga contents kasi nag-narrow yung part na yun. So, as you can see here, sa picture I have presented. So let's move on to the next example. So we have in here the fifth one is congenital conditions. There's actually a lot, but I have provided two. So for the congenital conditions, we have here atresia and imperforate anus. So first, atresia. An intestinal atresia class is a broad term used to describe a complete blockage or obstruction anywhere in the intestine. So stenosis refers to a partial obstruction, di ba? Yung kanina, yung sinabi kong may narrowing na nagaganap doon sa stenosis and stricture. However, here in intestinal atresia, talagang complete blockage siya or obstruction na matatagpuan in any part of the intestine. So, the second example under congenital conditions is imperforate anus. So, when the anus is completely blocked, the condition is called imperforate anus. In children with anorectal malformations, the anus may be missing, blocked by a thin or thick layer of tissue or more narrow than normal. In rare cases, the anus may be normal while the rectum is blocked or narrowed. So, congenital disorder pa rin siya na may block na nagaganap sa anus ng bata or hindi kaya wala talagang anus. And then, meron ding certain instances na okay naman yung anus pero yung rectum yung nakablock or narrowed. So, let's move on to the sixth cause or example, which is the inflammatory diseases. I have provided two again, which is the Crohn's disease and diverticulitis. So first, let's explain the Crohn's disease. So obstruction, this is the most common complication of Crohn's disease. This may arise from swelling and the formation of scar tissue. So the result is thickening of the bowel wall and a narrowed intestinal passage. These narrowed areas are called strictures. So the second one is diverticulitis. So in chronic diverticulitis, inflammation and infection may go down but never up completely. So over time, the inflammation can lead to a bowel obstruction, which may cause constipation, thin stools, diarrhea, bloating, and belly pain. So ito pala yung pagsiswell or pag-inflame ng walls ng intestine na sa katagalan or along with time, talagang na-obstruct na siya because of it. So, let's now move on to the intraluminal causes or examples. So, ano nga ba ulit yung intraluminal? This is a problem or obstruction of the intestinal lumen. So, yung problema is nasa loob ng lumen, kaya na-obstruct yung mga intestinal contents. So, first thing here we have, so foreign bodies, if a foreign body is partially or completely obstructing the stomach, the small intestine, or rarely the large intestine, may cause cramps, bloating, abdominal pain, nausea, and vomiting. So, as you can see here in the picture, may toothbrush sa intestine ng patient. So, nahihirapan na mag-pass through yung intestinal contents kasi may nakablock na foreign body. So, second example or cause is fecal impaction. So, a common type of blockage is called fecal impaction. This is when a large, hard mass of poop gets stuck in your digestive tract and can't get pushed out of the usual way. But when your bowel is blocked by something other than hard stool, doctors call it a bowel obstruction. Now, this one, merong poop na matigas and nahihirapan si patient na ilabas siya than usual. So, next example is the polyp. So what is a polyp? Bowel polyps are caused by an abnormal production of cells. The lining of the bowel constantly renew itself, and a faulty gene can cause the cells in the bowel lining to grow more quickly. So a large colon polyp can partially obstruct your bowel, leading to crampy abdominal pain. Iron deficiency anemia, bleeding from polyps can occur slowly over time without visible blood in your stool. So ayan, ang polyp pala is an abnormal production of cells. So may mga little bumps, as you can see in the picture. within the intestinal lining or wall. So, ayan, na-obstruct siya lalo na kapag malaki. So, ayan. So, the next example is gallstones. So, gallstones that are large enough to cause intestinal obstruction almost invariably reach the intestinal tract through a fistula between the gallbladder and the duodenum. So, the symptoms of gallstone obstruction are principally those of mechanical obstruction of the small bowel. The usual site of obstruction is the distal ileum. So, ayan, may mga gallstones. Lalo na daw kapag malaki yung mga gallstones. So, in post-operative patients, approximately 90% of mechanical obstructions are due to adhesion. So, yun yung sinabi ko kanina na after surgery, nagsistick yung mga intestines together. So, in non-surgical patients naman, hernia is the most common and is often inguinal cause of mechanical obstruction. So, for non-surgical patients, hernia is the most common for mechanical obstruction. Now, let's move on to the second type. That is the functional obstruction. So, what is functional obstruction? This occurs when peristalsis fails to propel intestinal contents although there is no mechanical obstruction. So, hindi siya pareho nung kanina na talagang physically yung pag-obstruct niya. This is more on the function of the peristaltic waves. So, may naghihinder, there is something that alters the function of the peristaltic wave. Peristalsis is ineffective or diminished motor activity perhaps because of it can be toxic or traumatic disturbance of the autonomic nervous system. Second naman, there is no physical obstruction and no interrupted blood supply. And third, it disappears spontaneously after 2 to 3 days. So, ano nga ba yung mga example ng functional obstruction? So, I have in here, 1, spinal injury. So, bakit, di ba? Bakit nakaka-cause ng intestinal obstruction ang spinal injury? So, a spinal cord injury or a nerve disease may damage the nerves that help control the lower part of your colon. This is the part of the body that sends solid waste out of the body. Now, this condition gets in the way of your normal ability to store and get rid of waste. It often causes constipation and bowel accidents. So, it will touch more on the nervous system na part din. So, yung mga nerves na nagsusupply doon sa intestines natin na injured or na-alter yung function, kaya na-alter din yung function ng intestines. Hindi sila nakakapag-work, and kapag hindi sila nakakapag-work, hindi na move yung intestinal content. So, nagbo-block sila. So, ayun. The second example that we have is the post-operative. So, normal peristalsis is slow to return after surgery. Kasi may mga medications na are prescribed after surgery na may affect intestinal movement. Post-surgical scarring can cause a blockage too. So, may mga medicines during and after the surgery. That's why nakakahinder or nakaka-alter ng function ng intestines. So, next example is pneumonia. So, pneumonia, bakit nga ba? Obstruction starts after a decreased transit mobility during pneumonia. Thus, inpisited food could cause the diverticular inflammation, which in turn obstructs the intestinal lumen. So, yan pala siya. Next type is strangulation. So, what is strangulation? This is obstruction that comprises blood supply, leading to gangrene of the intestinal wall. So, si strangulation, it occurs kapag there is prolonged mechanical obstruction. So, dun pa lang sa mechanical obstruction, kapag hindi na na-treat yun, kapag hindi na manage well, so nagkakaroon ng pagko-comprise ng blood supply. And so, nag-result ng strangulation. So, ano nga ba ang clinical manifestations ng intestinal obstruction? Now, sa lahat ng types, from mechanical to functional to strangulation, lahat sila nagmamanifest ng fever, peritoneal irritation, increased WBC count, toxicity, and shock. So, yan nagde-develop yung mga manifestations na to. Now, let's go to the simple mechanical, specifically sa high small bowel, low small bowel, and sa colon. So, let's first enumerate the manifestations under simple mechanical high small bowel. So, yung mga manifestations is colic, cramps, mid to upper abdomen cramps, some distension, early bilious vomiting, increased bowel sounds, or high-pitched tinkling heard at brief intervals. And lastly, minimal diffuse tenderness. So, let's move on to the simple mechanical low small bowel. So, the manifestations are significant colic cramps, mid-abdominal cramps, considerable distension, vomiting slight or absent, later feculent, increased bowel sounds and hush sounds, and minimal diffuse tenderness. Now, the last column in this slide, we have simple mechanical in the colon. The manifestations are cramps, mid to lower abdomen, later appearing distension, vomiting, or feculent, increased in bowel sounds, and minimal diffuse tenderness. So if you have observed yung cramps, sa first column is sa mid to upper, yung second column naman is nasa gitna, yung cramps, and then yung simple mechanical colon, yung third column, is mid to the lower part of the abdomen, yung cramps. So let's move on to the next slide. we have in here partial chronic mechanical and strangulation na manifestation. So here's a partial chronic mechanical. It may occur with granulomatous bowel and Crohn's disease. The symptoms are cramping, abdominal pain, mild distension, and diarrhea. So for the strangulation naman, as what I've said earlier na strangulation is the result kapag prolonged yung mechanical obstruction. So yung mga symptoms ng strangulation is similar with the mechanical obstruction. It's just that yung progress is rapid. So, pain is severe, continuous, and localized. There is moderate distension, persistent vomiting, decreased bowel sounds, marked localized tenderness, stools or vomitus becomes bloody or contains occult blood. So, yun yung mga manifestations ng intestinal obstruction. So, let's now move on to the pathophysiology. So, I have in here the flow chart or the diagram of the pathophysiology of intestinal obstruction. So, yung mga causes, there are actually a lot of causes, diba? As what I have presented earlier, but I only included few of those. So, the causes may be sepsis, anti-motility drugs, post-operation, and post-abdominal surgery. So, under sepsis, anti-motility, and post-operation, nagre-result siya ng nerves na nakaka-ordinate sa bowel peristalsis and nade-disrupt yung function ng nerve na yon. And so, nade-disrupt din yung peristalsis. So, functional obstruction yung tawag dito kapag walang peristaltic waves. So, dito naman sa post-abdominal surgery, nakaka-cause siya ng adhesions. Kasi as what I've said earlier, 90% of patients na post-surgery na nagkakaroon ng intestinal obstruction is adhesions yung cause. So, meron ding hernia, which is non-surgical. So, yung mga to, yung dalawang to, nagkaka-cause siya ng physical blockage sa lumen, which is what we call mechanical obstruction. So, functional obstruction and mechanical obstruction, nagre-result siya ng gas from swallowed air and ingested gastrointestinal contents to accumulate before obstruction. So kapag nangyari to, if complete obstruction, patient may manifest no flatus and absent bowel movements. If partial obstruction naman, decreased frequency of bowel movements, yun ang manifest ni patient. And when gas or air sounds hollow to percussion, is that patient may manifest hollow or abdomen tympanic to percussion. So, after naman na nag-a-accumulate yung gas from swallowed air and ingested gastrointestinal contents, itong mga to na na-accumulate na GI contents nagko-contain ng salt and other osmotically active solutes that osmotically draw water into the GI tract. So, as a result, mayroong irritation of autonomic nerves in visceral peritoneum. That's why patient may manifest bloating, cramping, anorexia, diffuse visceral abdominal pain. And it can also lead to lower effective blood volume, na nakakapag-lead to dehydration, and thus patient may manifest flat or low jugular venous pressure, resting tachycardia, orthostatic hypotension. Now, next naman na nangyayari after ng salt and other osmotically active solutes na nagdodraw is that may continuation of increased bowel distension and increased luminal pressure over time. So, as a result, continued peristalsis proximal to obstruction continues to push GI contents against the obstruction. So, patient manifests severe abdominal pain, peritonitis, guarding, rigidity, hyperactive bowel sounds, or absent bowel sounds. So, next naman is it may also result if obstruction is closer to the mouth, higher luminal pressure may force regurgitation of GI contents, and thus, patient manifests nausea and vomiting. So, after naman na nagkakaroon ng bowel distension and luminal pressure, merong increased pressure na nagsisqueeze sa intestinal blood vessels leading to decreased bowel perfusion. So, dito na tayo nagkakaroon ng problema because it may cause complications, which is bowel ischemia and infarction, tissue necrosis, possible perforation, and bacterial invasion. So, this is the pathophysiology, the flowchart, and the diagram of intestinal obstruction. So, that's it for my part. The rest parts of bowel obstruction or intestinal obstruction will be discussed by my partner, Ms. Regine Lim, especially the diagnosis and the treatment for patients who have intestinal obstruction. Thank you for listening, and I will now send you over to my partner.
Diagnostic tests, abdominal X-ray or CT scan. These tests may show presence and location of small or large intestinal distension, gas or fluid, word-baked lesion in colonic volvulus, and foreign body visualization. Laboratory tests, electrolytes, bun, and creatinine may be abnormal because of hypovolemia and vomiting. Elevated WBC counts because of inflammation, marked increase with necrosis, strangulation, or peritonitis. The lactate level may be increased if ischemia of small bowel is present. Contrast studies, small bowel follow-through with water-soluble contrast can be both diagnostic and therapeutic. Fecal material aspiration from nasogastric tube. Last is sigmoidoscopy or colonoscopy. This test may identify the source of the obstruction, such as tumor or stricture. Nursing diagnosis, acute pain related to obstruction, distension, and strangulation. Risk for deficient fluid volume related to impaired fluid intake, vomiting, and diarrhea from intestinal obstruction. Ineffective breathing pattern related to abdominal distension interfering with normal lung expansion. And risk for ineffective gastrointestinal perfusion. For the medical management, it includes decompression of the bowel through a nasogastric tube is necessary for all patients with small bowel obstruction. This may be tried for up to 3 days for patients with partial obstructions, and resting the bowel in this manner can result in resolution of the obstruction. An IV solution with electrolytes is initiated to correct the fluid and electrolyte imbalance, such as the depleted water, sodium, chloride, and potassium. Treatment of shock and peritonitis. A TPN may be necessary to correct protein deficiency from chronic obstruction, paralytic ileus, or infection, and antibiotics to prevent or treat infection, restoration of intravascular volume, ambulation for patients with paralytic ileus to encourage return of peristalsis. For the surgical management, surgical resection of the obstructed colon may be necessary. Laparotomy is performed to allow inspection of the small intestine and removal of infarcted or gangrenous tissue. And if the obstruction was caused by adhesions, these are removed or lysed. A temporary colostomy may be indicated to allow the bowel to rest and heal. An ileoanal anastomosis may be performed if the removal of the entire large bowel is necessary. A colonoscopy may be performed to untwist and decompress the bowel, and a cecostomy in which a surgical opening is made into the cecum may be performed in patients who are poor surgical risk and urgently need relief from the obstruction. For the nursing management, the nurse must monitor the vital signs, especially blood pressure, for indications of fluid balance. Assess the patient's abdomen at least twice a day for bowel sounds, distension, and passage of flatus. Monitor fluid and electrolyte status, including laboratory values. Manage the patient who has a nasogastric tube by maintaining the function of the nasogastric tube, assessing and measuring the nasogastric output, assessing for fluid and electrolyte imbalance, monitoring nutritional status, assessing for manifestations consistent with resolution, provide frequent mouth and nose care, and maintain the patient in a semi-Fowler's position. Give analgesics for pain as prescribed, and also the nurse's role in here is to monitor the patient for symptoms indicating that the intestinal obstruction is worsening and to provide emotional support and comfort. And if the patient's condition does not respond to non-surgical treatment, the nurse prepares the patient for surgery. This preparation includes preoperative education as the patient's condition indicates. After surgery, routine postoperative nursing care is provided, including abdominal wound care.